There are two main biliary diseases of pregnancy that come up in exams and are worth comparing side by side. So first of all, obstetric cholestasis is a condition in which patients develop pruritus without there being a rash. So in particular, in SBAs, they tend to explain that a woman presents with an intractable itch in their hands and feet, which just doesn't seem to go away, whatever they try. And if you do a blood test, you'll notice that there is an obstructive picture, so there will be likely a raised alk phos and also GGT. Although this perhaps doesn't initially seem like a particularly troubling situation, the risk that it's associated with is preterm birth. And the main issue is that it's very difficult to predict which patient with obstetric cholestasis is likely to go into labor preterm. So it's not necessarily correlated with the severity of the symptoms or the extent of the abnormality of the LFT, so it can be very difficult to predict. So the patients should have weekly LFTs, and delivery should be considered at 37 weeks when you feel that the benefits outweigh the risks. The symptoms can be managed with ursodeoxycholic acid, which can reduce that sensation of pruritus and bring about an improvement in the LFTs as well. Acute fatty liver of pregnancy presents a little bit more dramatically, so usually with abdominal pain, jaundice, nausea and vomiting, and it classically occurs in the third trimester. The issue with this is that it is actually a very serious condition which can cause patients to deteriorate rapidly, so they can develop disseminated intravascular coagulation and they can also die. So it's important to attend to it as quickly as possible. Patients will likely need ITU level care. The baby will need to be monitored and the baby will ideally need to be delivered as soon as possible. So the conditions do vary quite considerably in terms of their acuity and also in terms of how they are managed, but both are important to be aware of.